Good evening and welcome to The Square. Tonight's discussion is going to focus on medical negligence and malpractice and discover and find out what issues exist in the medical field and what patients, what sort of recourse do they have in legal redress. And we want to understand what measures are put in place in the medical field to address these issues, malpractice and negligence. And we're going to find out the difference between the two before we kick off. My name is Dan Mpisi, I'm the host of The Square. And tonight, on this issue, I'm joined with two guests. I'll start with you, Happy Mukama. Happy Mukama is an attorney at law and is here to shed light on the legal aspect of the topic for tonight.
Good, Anna.
Great to have you. On my right, I'm also joined by Dr. Emmanuel Rudakemga. It's not your first time on the show.
Yes.
Great to have you back. And you're here as the chairman of the Rwanda Medical and Dental Council. Thank you for joining
Thank you for
tonight.
hosting us once again.
Yes. As always, the show is joined by its resident panelists. Unfortunately, two of them are not here tonight, Bernard Namata and Ephraim Ngamenje. But Charles Haba, always a pleasure to have you on the show.
Thank you, Diana. How are you?
Good.
I'm hoping Ephraim and Bana are not away because gone abroad to seek medical
I don't think so.
attention.
I don't think so. I think...
Reliable medical
Exactly. No, I think they would trust our medical field here. But wherever they're, they'll be watching. So the first topic I'd like to kick off, and it's to both of you, to you, Dr. Emmanuel, and to you, Happy. But I'll start with you, Doctor. And if you allow me to read some facts, according to the Rwanda Medical and Dental Council, cases of medical malpractice doubled from 12 reported cases in 2014 to 27 in 2015 and 34 in 2016. But then the figure has gone. The cases of medical malpractice have declined since 2016, and but the most culpable departments in medical malpractice in Rwanda are gynecology, pediatrics, and surgery. So my first question, I'd like to ask you, Happy, and then we'll get back to the doctor. If you can shed light to our public, what is the difference between medical malpractice and medical negligence? The two words often interused, but I think they have different legal implications. If you can shed light on that.
Thank you, Dan. Actually, as you're saying, the two words seem to be intertwined. But right to put it, medical negligence is when a physician or any health professional deviates from his or private practice, and this deviation causes a harm to a patient. And negligence, medical negligence, sometimes can purport to be called a civil wrong, or if the harm is so grave, it can also lead into what we call criminal liability. So simply putting it, medical negligence leads into medical malpractice. If there's a harm, then it turns into medical malpractice. That's why even the law punishes both of them in the same way. That is in the brief about the difference between the two words.
And Doctor, I'd like you to also weigh in on this. If you can tell us right now, what is the status of viable options for patients who are victims of medical negligence? If there are lawsuits, are there any lawsuits that are happening in the country when there's medical negligence? And what legal recourse do patients have to take? Can they win lawsuits? What's the case at the moment? Especially because we know that the medical liability law is yet to come into effect. So what's the legal recourse for patients who are victims of medical malpractice or negligence?
Yes, thank you, Diana, and my colleague panelists. The main responsibility of the Medical and Dental Council of Rwanda is to protect the population as we guide the profession. Underline, protect the population and guide the profession. The issue here is there are so many assumptions in some of these practices. You know, no healthcare professional wakes up in his or her house to go to the hospital to do any harm. So that is why the assumption from the word go is that if anybody errs, if anyone commits a mistake at work because of so many other reasons, it becomes a civil suit. It becomes a civil tort. And therefore, under no circumstances in the civil law systems should you consider a medical malpractice or a medical tort or a medical error as a criminal liability to this practitioner. It's so unfortunate that we have had a mix of the two, to the extent that initially, actually, practitioners who would be seen to have committed a wrong would actually be paraded in front of the television and declared a criminal in front of the people that we serve.
Is this something you're saying that used to happen? Or?
Yes, it used to happen. Now that we have had some close discussions with the prosecution's organ and the police initially, but now we are actually engaging RIB to understand that a medical error, a medical malpractice, are things that normally take place. Even when you look at the world literature, these are things that take place for so many reasons, not because of a criminal intent. It actually becomes very difficult even to prove that what a healthcare professional did was intentionally aimed at harming a patient, but rather not because of probably knowledge, attitude, or practice. And we have seen some extreme, actually, allegations by the penal code where if you drive your car and hit someone, it actually becomes equivalent to somebody practicing the art of healing and harming someone, and they're actually taken to the same level, which we have tried to engage different organs of the state to understand that this is a civil tort. This is a civil liability as opposed to criminal liability. And essentially, this is the understanding. Though I'm not trying to exonerate healthcare professionals from doing what they're supposed to do and when they're supposed to do it, because actually you will find that the bottom line here is we expect a healthcare professional, and in this case doctors, to do what they're supposed to do. So we expect them to follow processes and procedures and standardized protocols. And to a large extent, we don't actually ask them of the outcome. So our expectation is not a positive outcome that comes out of treating somebody and he gets healed or gets better, but rather evaluating somebody and assessing whether indeed he or she did what he was supposed to do, despite limitations or despite availability of so many things that will support him to do what he's supposed to do.
I think I would like us to go to our tweets as we progress, because some of the tweets that we have echo some of the questions that you were asking. But before we go to this particular tweet, I want to bring to your attention, and Charles, I don't know if you're going to weigh in on this, the issue of this lady who had a mastectomy, a wrongfully misdiagnosed mastectomy, and you know, she had one of her breasts cut off, and the hospital, I think, was being told by the courts to, you know, pay a compensation fee. And how often do these cases happen where victims actually are compensated fairly?
I want
to weigh in?
Yeah,
Yes.
I want to weigh in on a general comment. There's just Dr. called me on, and that's the issue of parading. I think irrespective of doctors or whatever, and this is one of the areas where I think the judicial sector, especially police and RIB, have not perfected. The issue of parading, the moment you parade a suspect, in the court of public opinion, they are.
You're labeled.
Yeah, they are labeled guilty. And it is next to impossible. Even if that person is arraigned before a court of law and they are proved innocent, the court of public opinion has already sentenced that person to life. Yeah, so I concur with Dr.
But it shouldn't be done.
That should not be done.
Okay.
Yes. But,
yes. But that question also applies to you. Of that, you know, misdiagnosed And there's some stories you've heard in the Rwandan medical fields, you know, like that, and it's a bit shocking. So how often do patients, and you said it's hard to prove intention, but at the end of the day, someone has a breast that was wrongfully, you know, operated on.
Yes.
Like, how often do I'm trying to look at the patient's protection.
Let me help him, or maybe help you to understand this.
Yes.
Yes, I'm very aware of the case of a middle-aged young lady whom was wrongfully diagnosed of a breast cancer, and it resulted into a procedure that was performed because the lesion that was within the breast was presumed to be cancerous. And one of the ways of treating this lesion is by doing mastectomy, removal of the breast. So you could do mastectomy, you could do mastectomy with chemotherapy, you could do mastectomy with chemotherapy and radiotherapy. So those are standardized treatment methods. So here you're looking at the liability of different healthcare professionals. There's a person who did the biopsy. Biopsy is, how was the diagnosis made? This tissue was taken, given to a pathologist. You have a chain of specialists involved here. So you have somebody that has taken the tissue, given to somebody to analyze and tell. You know, in a hospital setting, we have people called pathologists, and particularly histopathologists. These are taken in our clinical care as equivalents of chief justices of systems like judicial systems. This is a person that tells you, what you've given me is 1, 2, 3. And based on 1, 2, 3, this is this diagnosis. So is it possible to make a wrong diagnosis? Yes, it happens. And there are millions of such wrong diagnoses given to patients, even in the so-called developed countries. So the issue here is, when I give you a wrong diagnosis and you are the surgeon, what do you advise this patient? Because we currently know that breast cancer is the most prevalent cancer in females. And particularly when somebody has got a family history, then this person is under risk of having the spread of this cancer. So as a surgeon or as a treating surgeon, you will advise this patient that I think the most appropriate thing is to remove the breast and save you from this cancer. Then maybe even advise having radiotherapy, trying to maintain, to make sure that this cancer is completely cured. Or even actually advise chemotherapy. We have had cases of where people have surgery, even have chemo, and to some extent have radiotherapy. There are two issues here. There is aggressiveness of the treatment, and there is the cost that is here involved. So that is one thing. So this has been a cascade of processes. You've had a wrong diagnosis that led to unnecessary aggressive treatment. What do you do in such instance? Particularly in a case like this one, where we had a peer review of the histology tissue that was co-reviewed by colleagues.
But this is after the misfortune.
Of course, yes. After
it's not part of the process. It's after the misdiagnosis, the breast was cut off.
Absolutely.
That's when you had a peer review.
Absolutely.
So Emmanuel, just in the interest of time, Doctor,
Yes,
I
yes.
want also maybe to hear from, because I understand the processes, I understand that, and I thank you for taking us through the whole cascade of, you know, the chain of how these medical decisions are made. But at the end of the day, that woman who had the misfortune of being wrongfully diagnosed, how easy is it to win lawsuits in such an event in this country? Like I said, the medical liability law is still stalling, unfortunately, which is really to the detriment of patients. So happy if you can help us understand in that, because of that gap, how do patients, how are they compensated?
Thank you, Dan. I think what the viewers need to understand is that there is health professionals owe a duty of care to the patients in the first place. And then negligence is actually a breach of the duty of care. There is an implied contract between a doctor and the patient. The moment a patient checks in the hospital, right from the word go, every health professional in the hospital has a duty of care to that patient, irrespective of the doctor who is going to take care of that patient. So in such cases, as Dr. Emmanuel was saying, there are two ways. One, there's civil liability in case of medical negligence, which does not have a grave harm. And in that case, a victim...
When you say grave harm, you mean the victim doesn't die?
Doesn't die.
So grave harm just means no fatality.
Exactly.
But it can be grave harm, like you have no limb.
Correct.
You have no...
What is less grave?
Exactly.
Like, how do you define
That
grave?
is another issue for debating
If
now.
they cut off your foot, is that grave? Is that...
That is another issue for debating. Now the court which appreciates what is grave. Now, in the first place, if there's negligence and it doesn't lead to harm, that is now where Rwanda Medical Network Council comes in for ethical issues, either to punish the doctor on duty. If again the victim, then again I think you have a chance. We shall have a chance to discuss the legal regime on medical liability in Rwanda. That's why now the victim has a right to go to courts of law and sue the doctor on duty or someone who's in charge of the patient for civil liability. And now if there's a grave harm, let's say someone has lost life, then that one leads to criminal liability. Again, to prove criminal liability, the prosecutor has to prove beyond reasonable doubt that there was criminal liability, because they need to prove intention.
Yes.
Which Dr. Iman was saying, it is very hard for a victim to prove intention, or maybe the intention that someone did this act intentionally.
Like deliberately.
Exactly.
Yes.
So the penalties are on three levels. One, the medical profession can inflict a disciplinary measure to the doctor. Two, the victim can also sue for go for civil liability, which is a tort. Then, if someone has lost life, then the prosecutor can come in to take the doctor in courts of law for criminal liability. But again, for criminal liability to be there has to be an intention. That one, prove it is very hard proving it.
Yes.
Yeah.
Okay. Charles, do you want to weigh in?
There's a bit of a problem there, because what Happy has explained to us is not comforting, and I appreciate what Dr. said, that it's a bit, no one wakes up in the morning to go to the hospital to cause harm to their patients. No one wakes up in the morning to go to the hospital not to treat their patient. But the challenge there, in a bit of a legality, is that the patient, or the patient's family for that matter, will only have redress, if you wish, in the event of a grave harm. And that's because that's the last resort. In as long as they are still alive, they'll still have hope that they can be cured. And I don't want to be in the shoes of the medical practitioners, because misdiagnosis is something that's...
It's a human error.
Yes, it may be to human error, but at the same time, the regular occurrence of such cases makes us think that, do the doctors with whom we live on our day-to-day lives exhaust all the options? I'll go back to Dr. with the example that Diana gave of the unfortunate lady. Did that particular medical practitioner exhaust all the options before they went to cut off the breasts? And I think therein lies the problem. That sometimes there is a quickness to say, this is what you're suffering from, and therefore the medication should be this. And I think therein lies the negligence.
Let me explain to you. I think part of what our patients are owed by the practitioners is that patients have rights. And the fact that
Which we're going to get to. So I'm glad you're ahead of the curve.
Yes. So the fact that patients have rights,
Yes.
It also underpins the fact that the patients have obligations. And so do the doctors or the healthcare professionals have a right? And so do they have actually the highest and the utmost responsibility in terms of obligations. When we are in the medical school and when we're in practice, we make sure and ensure that we encourage what we call multidisciplinary teamwork. To the extent that nobody thinks that he or she is an alpha and omega. This would mean that in an environment where you have multidisciplinary teamwork and multidisciplinary practice, it shouldn't be a discussion between me and you. It should be a discussion between me and you and her and him. To the extent that based on different scenarios, maybe there would have been a relook of this histology tissue, a relook of radiological findings of this breast lesion. But of course, there are some challenges to that effect. There is an environment where you find maybe 2 practitioners exist in a hospital, or 2 specialist practitioners are in the hospital.
Or in the country.
Yes, exactly. So, and that becomes a huge limitation. But that does not in any way give us a leeway to practice unilaterally or to make unilateral decisions. And the Medical and Dental Council actually in its code of conduct recommends and always advises the practitioners that you must try the best you can to involve your colleagues. So we understand. We owe it to the public we serve, because particularly if, as I said, you wake up early in the morning at 6:30 and you find yourself in the hospital at 6:40 or 6:45 or 7, and you're there up to 8, there is no reason you're there. You're there to serve the population that we swear Hippocratic oath to make sure that we shall not do any harm. So that can always be brought to the attention of the public. And whenever a mistake like that happens, that is why we always advocate to take that as a civil
wrong.
As a civil wrong.
Not a criminal.
Not a criminal
offense,
wrong,
so to
because
speak, yeah.
this doctor, we look at the knowledge, the attitude, and the practice. My having minimal knowledge cannot tantamount to the fact that I'm very. It might imply that I'm dangerous to the community, but it should not be in any way taken as if I'm actually a misguided bullet. Because these are things that need to be disentangled. I might have been trained poorly, and therefore I'm ill-equipped. And the fact that I'm ill-equipped, then I'm potentially dangerous to the community. But because we are still looking for numbers, we are actually
Compromising on people's lives.
That is not the intention, but it's a consequence. It's a consequence, yes. So what we are doing as the Medical and Dental Council is to try and streamline how our doctors are actually trained, to make sure that whoever comes out of a certain program is competent enough to be able to do the basic services to the population. And I think that is the right way we are heading to. You remember, just 20 years ago, we had less than 100 doctors. We are lucky that we have about 1,600 doctors. And out of these, about a third of them are specialists. And if you look at the number of specialists to the patient's ratio, that still becomes a challenge. So as you know, we are fighting with so many challenges, and thank God that we are where we are, and we hope to be much better than where we are in a few years to come.
Future.
Yes.
Yeah, dear Doctor, I'd just like us, before we go to the next topic, while we're still on this, I'd like to touch a bit on our Twitter feed, social media feed, just before we go to the next topic. And the first tweet in this regard is from someone called Rwakijenza, whose questions are: 1, do we have a legislated and functional medical records retention and disposal structure? 2, if not, how can medical negligence be proved administratively or in court? And 3, do we have a government body investigating suspicious hospital deaths? I think it's asking
If
both
I
of you,
could just
but-
go first,
yes.
then my legal colleague goes
Yes.
second.
Yes.
You know, part of what is trying to be put in place as we train more doctors, we are also trying to put in place, the health sector is trying to put in place a process of quality improvement. And this quality improvement is indeed a process and not a destination in itself. So what we are trying to do is that out of 45 district hospitals, most of them are having accreditation processes. And so what is accreditation? We are trying to have standards and guidelines being implemented in these district hospitals to the extent that people are deviating from what we normally call the usual, the routine. We are trying to make sure that every district hospital or every hospital tries to conform to a certain set of standards. To the extent that when you talk about having a way of doing things, it is standardized. So documentation, patients' documentation, patient records is one of the paramount criteria that are looked at. And so when I meet a patient, it must be documented. I must write down what I have found out. To the extent that if Charles comes tomorrow, he will be able to see that patient X was seen by me, and this is what I found out. This is what I diagnosed. So I think his question is answered through that.
An external body on suspicious deaths?
Yes. Yeah. If you know, that's what we are saying. And we are trying to essentially say that, and I'm very sorry to say this, doctors or healthcare professionals do not prevent death. Theirs is to do the best they can do to make sure that they improve the patient's lives when they come. When you have a curable disease, that will be cured. But when you come with a chronic condition that can only be facilitated and helped at, if I die because I have been having a serious chronic condition and somebody becomes punished, that is not right. So we ask whether this doctor did what he was supposed to do with the available resources.
Basically, it's okay. You guarantee the means but not the result.
Exactly. That is the point. That is the point. And that is the practice world over. We guarantee the processes and procedures that this doctor that went to school did not go to school to stop death. He went to school to do the best he could to treat this patient. But if the outcome is death, then you cannot hold this doctor responsible.
Happy, but can Happy just weigh in very quickly before you disagree with the doctor? But this tweet on, is there an external sort of body to regulate this negligence to a certain degree?
Yeah, actually, there's no external body, but there's the bodies we have are the bodies starting from the ethical grounds, right from Rwanda Medical and Dental Council, which checks the ethical grounds for its members, the doctors, and the whole spectrum of health professionals. Then, as far as the public bodies, there's a Ministry of Health supposed to be also doing the investigation in public hospitals and private hospitals to see how these services are being provided. Then, they're supposed to be reporting to see if all the services are being provided in the best way. But again, when it comes to medical services, as a consumer, we also have a body in Rwanda in charge of consumer protection, and also consumer protection associations, which are supposed to be where the victim can report. I don't know if this body in charge of consumer protection is fully functioning, but part of its mandate is to inspect the way services are being provided across the board. But then when it comes to health services, then the Ministry of Health comes in as a public body. Then consumer protection associations should also come in to chip in to help a victim. The victim can also report to consumer associations. The victim can also go to court straight without even going through the consumer association. So the bodies are in place. What is needed is just awareness.
But this medical liability, why is it taking long? Why is it in the...
Before you talk about the medical liability, would I just make a clarification on one point? We have what we call professional regulatory bodies that are set by acts of parliament that are supposed to be autonomous and independent. And by the mere act of self-regulation that has been put in place, the professionals are supposed to hold each other responsible. That is critically important. So when you're talking about, is there a body that is supposed to follow up on the wrongs being done by the professionals? That body is there on ethical grounds.
Yeah.
To the extent, if there is a reason to think that there has been criminal liability implied, then we have Rwanda Investigation Bureau. So the bodies are there. Then, of course, you have the consumer protection and all that. So the issue here is rather, are these bodies fair,
Equipped.
honest, and are they actually able to judge, to bite? And we do.
And do patients know them?
Yes, and do patients know them? And I think that's why we have to thank Square for doing this. They must know that bodies exist, and we actually do a lot of work. From what you had said, there are conditions that are notifiable. And that's why you see that we have lots of maternal and child health cases compared to other cases. So, and this is a government's commitment through so many World Health Organization engagements, to the extent that if a mother dies while giving birth, that is a notifiable condition. So that case must be notified. And when it becomes notified, then it becomes extremely important that that case gets investigated. And the results are always there for everybody to see. So, of course, other conditions may not be notifiable, and those that are not notifiable then definitely may fail to surface as much as the mother and child health cases might be notified. And that's why you're seeing that the curve is relatively higher with the maternal and child health cases.
Charles?
You know, I've been with a good doctor on various fora that it's always a bit difficult to twist him and you win.
I can see you're holding it in tonight, sir.
Yeah, but my bigger worry is around the end result that comes out of negligence. And there's no second chance to this. And therefore, under no circumstances should we be taking these matters lightly. Because one simple error will lead into a fatality.
Correct.
And my biggest concern, Dr. is the teeth that we are talking about earlier on. Under no circumstances...
The teeth of the regulatory bodies.
Yes, yes. Should we allow underqualified people to be exposed to a situation where they can actually sentence somebody to death? It's like getting a grade 1 magistrate in the Supreme Court. Yes, and that is the situation in which we are. And I want to exonerate you a little bit from this, Dr. and blame our system in general. When you look at, I appreciate that we are coming from 100 doctors.
Less than 100.
Less than 100 doctors.
Actually, the doctor-patient ratio is what?
1 to 16,000.
Not 10,000.
Yeah, we have about 1,600
Okay.
Yes.
for 12 million people.
Yeah, for 12 million. Yes.
The numbers are clear.
Yes.
Not too clear to Happy and I who read letters. But
Yes.
I think that, yes, the ratios are alarming. The point I'm raising is, notwithstanding what we had 25 years ago, 100 doctors and 1,600 today. What has been put in place and to ensure that we narrow that gap? You train to motivate so that you can retain. Our system does not have a clear retention policy, and the reason for which we have many qualified doctors who are not practicing. And I thank you for thanking the Square, because I'm a very strong advocate on this. I think the government of Rwanda has fallen short on this one. The number of people we have who are traders in town, who are doing all sorts of businesses,
But are trained doctors.
They are not motivated to remain in the medical practice. And you end up having quacks sentencing innocent patients
Mastectomies.
Yes, that one. You know, is very, very disturbing. So I think the government of Rwanda needs to do a little bit more in terms of motivating to retain. We can give a few more examples, but I think, especially in terms of your advocacy in the Rwanda Medical and Dental Council, it is something that you need to make a lot of noise on, Daktari, to ensure that we have as many. We haven't lacked them. The government of Rwanda has spent a considerable amount of money in training people, but when it comes to closing,
Retention.
yes, closing. There used to be a school of medical and nursing in Chibuye, I think Karonji at the time. Or it's, I mean, what is it producing? Or if I'm told it was closed. So we need numbers. We need numbers, and I don't see a deliberate government effort to ensure we have numbers to close this gap, but also most importantly, to retain them by motivating them to stay in their jobs.
But very quickly, sorry, I have to take us forward because we've been talking about liability, compensation, the law, or lack thereof, because it's not yet out, so to speak, the medical liability law. But at least thank you for sharing some insights, Doctor and Happy, on the legal aspects of compensation to victims. Patients who are victims of negligence. The next part I want to take us on is to do with patient rights. And you'll definitely shed light on this, Dr. Emmanuel and Happy. And on this, I'd like to touch on the issue of referrals. So it is common practice for hospitals in the country to deny patients referrals or transfers. Sometimes, at least to a layman's perspective, based on, not accepting that they can't save a life or the condition, and they delay in giving referrals. If they don't delay, they just don't give them, and it's really often to the detriment of the patients. So in terms of patients' rights, if I went somewhere and I had a condition whereby at Faisal they can't treat me and they're delaying to give it to me, and I can see they're trying everything, or they're really negligent in the time period to get back to me, and I want to transfer and go to Nairobi, why is it that doctors take their time? How can patients be protected from such issues when it comes to transfers or referrals? I don't know the exact medical term you call it.
Yes, thank you very much. I think we have a national patients' rights charter.
Yes.
We have what World Health Organization regards as patient charter, and Rwanda has subscribed to that. So all the patients' rights are observed. We have a national, at least to the best we can. And I think we need to indicate that when you talk about national referral system, you're talking about rational utilization of national resources. When somebody is referred from the lowest level of the healthcare sector, and that is from the health post, to a tertiary care service center like CHU Car. Let me exclude King Faisal because it is presumed to be it is presumed to be private, but it is of course a government hospital. So the healthcare system, the referral system is in place to make sure that what I cannot manage, I send to my colleague who can do better. Why doesn't that take place? There are so many facets to that point. Is there anything that can happen? Because actually referrals take place. That's why you see CHK full. That's why you see CHU Bay full. That's why you go to Kanombe and to Rwanda Military Hospital and you find it full. That's why you go to King Faisal Hospital and you find all the beds are full. Even the mortuary is full. So this means that the referrals take place. But are patients referred the way they want? Or are patients actually preference for referral to certain hospitals a mandatory actually requirement for the national referral system to perform to the expectation? No, because I refer you because I say this is what I cannot manage here, and therefore I'm going to send you to Charles, who is going to do 1, 2, 3. Because when you refer a patient, I write, this is a condition that I'm faced with. This is what I want you to do. I cannot do it here because I lack 1, 2, 3, or I don't have these competencies. Then you refer the patient. So referrals take place. And when you talk about
my issue is not that they don't
abroad.
take place. My issue is that, yes, they take place, and you really illustrated it very well. My issue is the manner in which they take place sometimes is to the detriment of the patient. There are some cases that you hear whereby they're just not given, number one. If they're given, they're really delayed. Maybe the doctors are trying, you know, at the back, trying to find a solution.
It shouldn't happen like that.
But it happens.
So, if a referral has to be made, it has to be made on time. Yes. Because the ultimate goal of the referral is to save somebody's life. So if you refer somebody to go to a beautiful mortuary, that is useless. So you should refer a patient to go and be treated and have a life. I think that is, if you look at the inspiration of our national referral system, that is towards that.
But the reality,
and there is a contra referral system as well.
But the reality, unfortunately, on the ground,
unfortunately,
maybe what Dan is trying to put across is that is a referral a right, or it's based on discretion from the doctor on duty?
It's a right.
So the patient should, if they insist on being referred, they should be.
You see, in clinical practice, we have what we call a patient's education charter. A patient has to be educated on the condition he or she has. And once I have accepted my condition, actually understanding your disease condition is halfway managing it. Because most of the chronic conditions, actually you find that patients have close to 80% responsibility in managing them. So once I have not been educated and therefore do not know how to best manage my condition, then I will have some claims, I will have some expectations that are actually even not necessary. However, when I have been educated and say, Charles is in Seashuka, we don't have him here, find him at Seashuka, you have a right, and it's my responsibility to make sure that you get referred to this rightful doctor.
Charles, do you want to weigh in on this?
Of course, there's something Dr. mentioned earlier on about managing the resources that we have. The Rwanda Medical Referrals Board does not operate an endless budget. I'm sure they operate a shoestring budget. It is therefore the responsibility of the CEOs and these other people in all these hospitals to ensure that they don't make the medical referral board run broke. So Diana, in case you think that all these hospitals, Seashika, Seashibe, and King Faisal will keep referring people to the medical referrals board to go abroad for better or whatever treatment. I think keep dreaming.
But why? Because you're saying they'll keep them there deliberately.
There is a huge aspect of managing the resources that we have.
But first, wait, I want to get you right, Charlie. I mean, jokes aside, keeping on dreaming.
I'm extremely serious about
it. So you're alluding to the possibility, we don't know for a fact, that they'll keep the beds occupied. Is that what you're saying? And not easily give to transfers or referrals.
To the fact that they could, there is a high possibility. Please remember what the good doctor said.
Resources.
That in as long as it is manageable, they will continue managing it. If a condition is manageable and the doctors deem it within themselves that they can manage that situation, they will continue managing it.
And there's no need for referral.
Yes, and there's no need for referral.
But you know what I'm talking about, Charles.
Yes,
cases whereby...
Let me help Diana.
Yes.
Diana is...
On behalf of viewers.
Yes,
it's not a personal...
Yes. On behalf of the viewers.
Yes.
Let me tell you, I think I told you about the national referral system.
So sorry, let me interrupt you a little bit. Also consider the fact that not all referrals that go to the medical referral board are necessarily referred abroad.
Yes, of course.
Yes,
of course.
Some are rejected and taken back to be managed.
I think that's what actually I wanted to say. So there is a national referral system where patients can be referred from the health post to the highest hospital levels that you can think of. And then there are those conditions, because I said that we have a limited number of specialists. So there are conditions that we cannot manage. One, because we probably don't have the requisite human resource capacity. We do not have the technology required. We do not have probably the multidisciplinarity that we are talking about, because you may find that a certain condition might require more than 4 sets of treatment modalities. And this one, then it is within the responsibility of the nation, because the patient rights actually get emanated from the national rights. So a patient has, the Rwandans have a right to good health care system. So when we know we cannot manage your condition, Charles, and we know it can be managed somewhere, and we have the resources, we send you. And there is a national referral board constituted, as catered for by the law, and people sit, and within their determinations, they decide who goes, who does not go, without fear or favor. So, but one, because of the good prognosis that they see. 2, because of the resources available. Because you know, as I can come to your boutique and say, give me this, I will pay you tomorrow. You cannot refer a patient to Israel or to India or to France,
just like that,
and say, I will pay in the next 2 months or 2 years. So you have to have the resources to send this person to go for treatment. So this is critical.
It's critical. But I'd just like to reiterate, maybe when we have part 3, because this is part 2 of our medical field. You know, you were the first one on the show, and you're talking about the medical quality of medical care in Rwanda. But yeah, the issue also of referrals that are delayed, I think it's something that shouldn't happen, but unfortunately it does. But thank you for explaining, you know, the whole the logic behind these referrals to start with. I want us to go to a Twitter feed before we continue. And this tweet is from Berna. Berna, who's not here, has a tweet where she talks about, this is basically quality of healthcare from the medical practitioners. She says, there's a tendency among the few specialists to work long hours which undermine care and contribute to errors or malpractice. We need strict enforcement, working hours, especially popular doctors. Now, we have a ratio of one doctor per physician, one physician per 16,000 people. Isn't that so, Dr. Emmanuel? The idea is to have 1 physician per 10,000 people by 2020, which is next year. I don't know the practicalities of that happening, but what do you think of Brenna's tweet? Is she in a utopia
I think
where she thinks that working hours can be, you know, managed, or based on this patient-physician ratio? Can we afford this? Can we afford to do this?
No, the issue is, Charles talked about motivation, hiring, motivation, training, staff development, and then retention. You know, these are things you find every human resource manager has got this policy clearly illustrated. However, when it comes to a country like ours, where you have got so many competing needs, the issue here is to look for lots of monetary and non-monetary incentives to make sure that our doctors are retained, particularly in the public health sector. The issue here has been actually trying to, the labor code permits that I can work at King Faisal and work at CHK and work at Rwanda Military Hospital, as long as I do not compromise my initial employer. So the issue has been actually, and there is, I think, a ministerial order in the line, trying to see how we can legalize and allow doctors to work in more than 2 places, or actually create private practices in the public hospitals to make sure that these doctors do not leave where they work at, but remain there, such that if there is any emergency from the public side, this patient is attended to. So this actually, because we have a small salary for these doctors, then they need to supplement. And the way they supplement is to look for alternative jobs elsewhere. So it is true that we have a doctor working in more than 2 places. Is it tiring? Yes, it is. But what is alternative? Alternative is not being able to foot the bill. So the issue here is, I think it is probably a temporary hurdle currently, because our doctors still have a low end of the pay. But and the government is, I'm told, in the processes of trying to review the payment structures based on so many scenarios, including what we call rare skills, rare specialties. So when you know that you have got only a single neurosurgeon or only a single plastic surgeon or 2 plastic surgeons or neurosurgeons or any other specialty you can talk about. You cannot afford to have this specialist work 24/7 because it's going to blow out. And if it blows out at the point of maximum need, then you're going to lose everything.
Actually, Doc, that was my main concern and part of Bernard's with the second part. If a specialist or a doc is overused, he might even need to an error of judgment because of fatigue. And this might lead into a case of medical malpractice. As much as we have a few physicians, we should put in measures to see how they can be used in an appropriate way to avoid such risks.
Such risks,
Yeah.
yeah. We have the last tweet from Berna as well. I feel like if she was on the show, she would really, she'd be going hard. So this tweet from her is, we need a shift towards patient-centered healthcare that ensures patients rate or judge the quality of their healthcare regularly. It is this regular feedback that should partly determine doctor remuneration, not working hours. What do you think about that?
I'll come to what Bana is saying, but
Yes.
part of the lobbying that the medical council should be doing is Rwanda Revenue Authority, when it comes to the taxes applicable to remuneration, pay as you earn, and everything else, they only consider the first income that is subject to pay as you earn and your pension and all the other wage bill deductions. When it comes to your second income, you must pay 30% of that gross.
Correct.
And the point the good doctor raises about rare skills, I think you should really lobby very hard for Rwanda Revenue Authority to understand that you need to be motivated, that if you've already been taxed, and I don't know whether you guys are having this discussion, or if you are not, it's definitely one of the big thorny issues.
You probably don't know.
Yes, you probably don't know, because if the guy is going to earn, if he's working at Seashka and then he does an hour in Legacy and another 2 hours in Baho, he's being taxed 30% on the one in Baho and another 30%. At the end of the month, he looks at his net and is like, what am I doing in this country? I may as well go to Papua New Guinea where better utilized. So I think that would be another way. I think the other one is, I've been told Rwanda is one of the countries where doctors have to pay consultation fees when they are going to a medical facility. So if you want to go, for argument's sake, to Bao Hospital to get treated, you pay consultation fees.
Correct.
But
Yes.
why shouldn't they? Because they're doctors. They shouldn't pay consultation fees to another
So-
doctor?
One of the ways in which you motivate them, please go back to the to
Retention, motivation.
Yes.
Doctors should get free services or consultation services.
Yes, from a fellow doctor, because it's going to be reciprocated anyway.
But how do you
And
prove?
they are
What if-
human beings?
But how do you prove you're a proper doctor? If I forge my papers.
They have
No,
licenses.
but what if they forge their papers?
Let me
Yeah,
tell
okay.
you,
But there's a
that
couple
is
of-
actually one of the things that we are looking at.
Yes.
There is a set of retention and motivation strategies. There are those that, as we said, that require probably a government support budget, but there are those that can be worked on essentially at a policy level. Like that, the issue of taxation, I think where you have like double or 3 times taxation, issues of this reciprocation of the services to colleagues. In the region, actually, it happens, we know. But, you know, this
Oh, it
has
happens
not
in the
been the norm.
regions?
Yeah.
We're the only ones who don't do it in this
Wow.
region.
So we're
there's-
sleeping on the
You know, we
retention.
have a culture, and culture dictates what you do.
Yeah.
So the fact that people have not been brought up in such a spirit, you know, even changing is not as easy as you would want. So the Medical Association advocates for that. That's not a responsibility of the council. Only the council can advocate. But somebody that can go into it and run through for the welfare of the practitioners are the association or the union. Otherwise, our primary responsibility again is to protect the population and guide the profession.
They're the profession.
And that does not exclude the fact that we also protect the profession when need arises. However, those are some of the things that have been put on the table, and there is, I think, even a policy framework that is coming out. And, you know, I said we have so many competing needs. Right now, we've been in the elimination of hepatitis C, which is a huge problem for the country.
Actually, globally as well.
Yes, globally, yeah. So, so when you look at that, you look at HIV, you look at TB, you look at malaria, you look at that, and then you look at the doctors. It's not to say that we are number 5 or 6 or 10, but these are all things that actually get slices from the small cake that is available. So we understand that.
Yeah. Yes, because we're about to close the show. If your remarks can be your closing remarks.
Oh, really?
Yes. Unfortunately, time goes very, very quickly on this square, but we have to respect it. So if you can give your closing remarks with the
closing
comment
remarks
you're just about to give.
The comment I wanted to give it to Dr.
very
Emmanuel.
quickly.
There's the issue of complementarity in the medical profession. A patient appears before a doctor. He has a medical condition. The doctor prescribes, the drug. He goes to the pharmacy. He buys this drug. Then after 3 or 4 months, then the patient has an allergy. So I would like maybe briefly the doctors to brief us where the role of the doctor ends and where the role of the pharmacist starts.
That's a very, very good point. But unfortunately, Dr. Emmanuel, we really don't have time. I'm looking at the clock and we have to respect the time. But this is actually a comment one of our viewers on social media asked, like, what is the role of pharmacists? And I'm glad you brought it up. Can you give your feedback in less than 20 seconds?
Yes, please. I think allergies, everybody has got different reactional mechanism. So it may not be a liability for the doctor or the pharmacist. But once you get exposed once, then you know that this is an X. You can't receive the same medication. So what I would like to say in a nutshell is that the Medical and Dental Council is there to protect the population and guide the profession. And we do this through guidelines and standards in place, through making sure that the doctors that go out on the market are very well trained, both at undergraduate and postgraduate. And then once they get into the practice, then we closely monitor and follow up on the excesses that they may have. And therefore, let nobody be under any illusion that we do not sanction doctors. They get sanctioned. We warn them, reprimand them, suspend them, even erase them from the register. So those are some of the things.
Thank you. Thank you very much, Dr. Happy. Thank you for joining the show. Unfortunately, we come to the end of the show. Charlie, always a pleasure to have you.
Pleasure.
Dr. Emmanuel, thank you for coming to the square for the second time. And your insights are always very valuable in the medical field. To our viewers, I'd like to thank you for watching. I would like to thank our partners, Uzi Collections, as well as Bourbon Coffee. And I'd also like to thank you for tuning in. See you again next week and have a good night.